So I'm going to take us through the Detect Child TB project in Uganda. And the presentation really highlights the issues, dynamics around translation of research into policy and practice. And maybe just to go back, so this project was implemented by the union, and I'm presenting on part of the teams whose logos are included below: the union, the National TB Program, Ministry of Health, Baylor College of Medicine, Children's Foundation Uganda, and Mildmay Uganda. So that's the order of presentation, the context, the project implementation and results, and a few slides on translating this into policy. I thought that we would start off by looking at the country profile, and I'll focus particularly on the section that includes the child TB indicators. So this is data for 2021 as extracted from the Global TB Report. And the performance was lower by the time the project was implemented. So we are currently at 78% treatment coverage. And this refers to the proportion of children that are diagnosed and started on treatment out of those that are estimated. And then a success rate is 74%, and a TPT uptake for eligible under 5 contacts is low at 34%. So this work has been published, and these articles can be found online. So the aim of the project was to strengthen district and community level healthcare delivery in 2 districts, and that is Kabarole and Wakiso. So it was focusing on children 0 to 14 years. The project design, this was a 2-year project implemented between 2015 and 2016. It was the first of its kind in the country. And the main focus was to decentralize child TB services from tertiary hospitals to lower level health facilities. And at that time, most of the care was provided at the tertiary level hospitals and referral hospitals. And there was a component on contact tracing and also facility level interventions. So what did we do? So we had 2 approaches, one on capacity enhancement at the facility and capacity enhancement within the community. So we did train health workers, and this was done in a systematic manner. We had district mentors who were trained, and we identified 15 district level trainers. So these were supported to train healthcare workers per facility, and all TB diagnostic and treatment units within the focus districts were engaged. We also trained community health workers, at least 2 per health facility. And subsequently, we conducted mentorship at the facility, initially monthly for a quarter, and then quarterly thereafter. We also supervised the teams and had performance review meetings to follow up on performance. So what were the results? We did document increased case finding for both child and adult TB cases. Over the 2 years, a total of 573 children were diagnosed with TB. Significantly, majority were from the facility. So for this project, 92.5% of children diagnosed with TB were from the facility arm. And these are findings that we also saw within the CAP TB project for those that participated in the dissemination yesterday. So we had 7.5% identified from the contact tracing arm. We documented improved treatment outcomes from 65% to 82% for both districts combined. We also had high uptake and completion of TPT for eligible contacts. And we did document an increase at that time from 5% to 72%. So we're able to demonstrate the increase, as you can see on this graph. And that reflects the proportion of children that are diagnosed with TB. This is an interesting figure. So the first bar looks at the baseline. We had a baseline assessment where we looked at the provision of service delivery. And what you can see is that 97% of the service delivery was at hospitals. So we did, and that is for Kabarole. For Wakiso, it was at 95%. So we repeated the assessment at the end of the study. And you can see that we had case notification at the various levels of care at the end of the project. So really highlighting that it is feasible to decentralize capacity, and the children will be able to access the services closer to the community and probably improve on the treatment outcomes. So what lessons did we learn? Clinical diagnosis is critical. Supporting capacity health facility teams via training and continuous mentorship. Diagnosis of TB is majorly clinical. It's different from adult TB, where you'll have a bacteriological confirmation for most of the time. So without supporting the facility teams, their confidence might not be enhanced. We also at that time used the online course for the union, which has been updated to enhance capacity. The role of community health structures is really critical, and this cannot be overemphasized. The challenges that we did face were related to documentation, especially for the community teams, but also, as mentioned by Daniel in his presentation, challenges related to contact screening and management, which I will not go into detail for purposes of saving time. So we concluded by saying that it is feasible to decentralize care, and engaging village health teams is critical. Now, we had those results at that time. So how did we translate the findings into policy? And which is something that is critical here. We've listened in on the various presentations, TB speed, and many findings. Commonly, we see that the academia, the researchers do these studies, very good work. Work is published, people go to conferences, and even the countries where these studies are conducted do not benefit in terms of policy translation. So I wanted to take us through some steps. Probably will pick something. So upon conclusion of the study, we did engage the stakeholders. As National TB Program, we have a pediatric TB committee that meets quarterly, and it's the technical wing for the National TB Program. It is chaired by Dr. Eric Obdea. So we did present these findings, and the committee agreed that we forward this to Ministry of Health Senior Management for endorsement. The numbers were visible, decentralization was visible in terms of capacity. So we did present to Ministry of Health Senior Management, and this approach was approved. We did do resource mobilization and allocation. The project was very expensive. The community arm, Daniel, how much money did you spend? You can't even mention. So community studies are very expensive. So we did do some bit of resource mobilization, And the information included there is particularly focused funding. So we have the implementing partners doing integrated contribution, but that for Global Fund is focused funding to scale up the approach. So we initially received funding to scale up to 10 districts, and now we have additional funding to sustain in the initial 10 districts and scale up to 40 additional districts. So we identified the districts using data performance. We reviewed and updated the orientation package for the health workers, and we oriented the mentors. That is for the initial scale up. We also oriented the site level teams, and we combined quarterly on-site mentorship and support supervision. So we're not able to do the project copy paste because it was very expensive. So we came up with a hybrid of sorts, and we are able to review performance. So this is a map that shows the districts where we are scaling up. The ones that have the pink dots are the initial scale up districts. So we are in 50 districts now. So for the scale up to 40 additional districts, we've completed training of the district mentors. I'll show you a schema on the enhanced approach. So as we implemented in the initial 10 districts, there were lessons learned. Low index of suspicion, limited confidence. We were not doing the monthly mentorship, we were doing quarterly. Transfer of health workers across care points. Today you train a health worker, the next time you go to mentor, they are in the theater. So then you have to orient again. Suboptimal implementation of contact tracing, and this was also varied across the different districts. Competing national and subnational priorities. So we are all competing for the same health worker. I usually share a scenario. A time we went to mentor, there was the nutrition team, there was immunization, then TB. We were all waiting for the same health worker. And then at the district, they also have priorities. So how do we fit into the district priorities? We had to plan with them, reach out to the district supervisor, the DHO, and plan together so that by the time the team goes, the team is ready to receive them. COVID-19 related disruption in activity implementation, and we did not have the luxury of the big resource envelope to implement the way the project was designed. So we documented opportunities. We are now integrating QI, and there's an opportunity to integrate other successful innovations. We've learned from CAP-TB, we have learned from TB Speed, and moving forward, these are things that we are going to take back to the committee, and we devise ways of integrating, and that will enhance our policy adaptation. We also have regional implementing partners that support us, and the opportunity for focused funding. And we also learned experiences from COVID-19 by directional screening and other related interventions. So this is a schema of what we plan to implement. So the black is national level, the brown or orange is regional, the blue is district, the green is facility. So at national level, we review the package. We also train national level teams who in turn train regional level mentors. So we have identified regional level mentors. For the Southwest region, we have 4 districts that are part of the 50 districts, and we have identified regional mentors. So these mentors will interact with the district level. And if you notice, the black stops at the district orientation. So in a way to enhance subnational capacity, we are saying that the regional teams should support the district teams, and the national level will come in to receive feedback from the regional mentors. And then at facility level, on-site orientation and mentorship will be done by the district mentors with oversight and technical support from the regional teams. We have also integrated QI learning sessions and a component on TB in the context of school health. We are receiving several informal reports of clustering TB cases in schools. So we plan to orient the health workers. If they identify a child with TB, they should go on to ask if this child is attending school, especially if they are bacteriologically confirmed, and link with the district teams to conduct contact tracing and provide support. So that is the schema. This is work in progress. I know when we, during the pediatric committee meeting, we shall critically review CAP TB and TB speed results or findings and integrate the approaches within the schema. I wish to acknowledge Government of Uganda, the development and implementing partners, subnational level leadership, healthcare workers, community. This is not in any particular order. Thank you very much.